Hello guys, today we will be discussing facial nerve reanimation. I'm Dr. Ankit Vishwani, your faculty for head tech surgery. Before starting facial nerve reanimation, we'll be discussing some basics about the structure of a nerve, what is epineurum, perineurium, endoneurium. We'll be discussing Sunderland classification of nerve injuries, and then electrophysiological testing, and then we'll go to the topic in proper. So the most important nerve in head neck surgery is the facial nerve. What is the structure of a nerve? The nerve is composed of multiple axons. So here you can see each axon is surrounded by one endoneurium, and multiple axons with multiple endoneurium are surrounded by perineurium, which is the pink structure, and two three bundles of perineurium are surrounded by epineurium. So epineurium is the covering of the of a nerve. This is a nerve structure, and individual unit of a nerve is axon, which is covered by endoneurium, and multiple endoneuriums are covered by perineurium. Initial classifications of nerve injury, which came earlier classifications, used to talk only about neuropraxia, axonotomesis, and neurotomesis. So, what is neuropraxia? Neuropraxia is an inflammatory condition where there is block in conduction, there's block in conduction of exoplasm. Then comes axonotomesis. What happens in axonotomesis? There occurs injury to the axons. Whereas in neurotomesis, there is injury to the nerve. So we'll be discussing this in detail in the Sunderland classification. So as I already told, neuropraxia is partial block to flow of exoplasm, and there is the recovery of function is complete in neuropraxia. There is no synkinesis. So now that is grade 1 of Sunderland. Then grade 2 of Sunderland is loss of axons, where injury occurs to axon but the endoneurial tube remains intact. So during recovery, the axons grow into those respective tubes only. So the result is good of axonotomesis also, because there is no cross linking or there is no synchronicity. There is injury to axon, and the axons grow in that same tube of the endoneurium. But now the grade 3, grade 4, grade 4, 5, all three are neurotomesis. So what is happening in neurotomesis? In neurotomesis, either it is injury to the endoneurium or to the perineurium or to the epineurium. So when there is injury to endoneurium during recovery, the axons of one tube can grow into other tubes, so there can be synkinesis. When there is injury to perineurium, which is also called as partial transection, the scarring will impair regeneration of the fibers. And when there is injury to epineurium, that is, there is a complete nerve transection. So these are the 5 grades of injury. So you can easily see in this classification, the initial classification was given by Seddon in 1942, which included neuropraxia, which is a transient block, then axonotomesis, which is in which there is axonal damage, but the lesion is in continuity. But in neurotomesis, the lesion is not in continuity. There is chances of cross innervation leading to a poor outcome. It can be of three types. Part 3, where there is injury to endoneurium. Type 4, where there is injury to perineurium in addition to endoneurium. And in type 4, there is complete transmission. There is injury to epineurium also. So it's easy to remember if you go through this table about the types of injury, because this can be a question, or it can be a part in it can be one of the options if they are trying to keep a question on facial nerve reanimation. One question definitely comes from facial nerve reanimation. Now, coming to the topic in proper, first we'll be quickly revising the course of facial nerve. As you all be remembering from your MSc NT days, the course of facial nerve is composed of an intracranial segment and the extracranial segment. The intracranial segment is limited to internal auditory meatus, where it is called as meatal segment. Here you can see the transverse crest and the vertical Bill's bar, and facial nerve. You can see the arrangement of facial nerve, superior vestibular nerve, inferior vestibular nerve, and the cochlear nerve. So superior and anterior are the facial nerve, posterior is superior vestibular, then inferior vestibular nerve, and the anteriorly and inferiorly is the cochlear nerve in that internal artery meatus cross section. Then more important than this is the extracranial segment, which starts when the nerve comes out of the internal artery meatus. The first segment is the labyrinthine segment, which is in the labyrinthine part of the inner ear. So it is the shortest and the narrowest segment, and it goes up till the first genome. So this is the labyrinthine segment. It is the shortest and the narrowest segment of the facial nerve, and it comes to the first genome, which is the process of cochlear polyps. And from the first genu processes cochleoformis to the to the oval to the part between the lateral semicircular canal and the oval window, that is the second genu. It is the horizontal segment. So horizontal segment starts from first genu, that is processes cochleoformis, to second genu, which lies between lateral semicircular canal and oval window. And then the mastoid segment or the vertical segment is a lies starts from the second segment and goes down till out from the stylomastoid foramen. And from the vertical segment, there are two branches. One is the nerve to stapedius. One nerve goes to stapedius muscle, and one nerve is the chorda tympani nerve, which arises from the vertical segment. So this is the just revision of your basic facial nerve anatomy, which is important to understand the subject. So I just added these two photos from Bhingra. Now, coming to labyrinthine segment, as I already told, it is the shortest segment of the facial nerve and also is the narrowest segment of the fallopian canal with a diameter of only 0.68 mm. So, in this part, facial nerve is most prone to inflammatory injury. Suppose there occurs a Bell's palsy or there is a that is the herpes virus infection is there in the facial nerve. So, the facial nerve will get edematous and it is prone to compression because it is the narrowest part of the fallopian canal which contains the facial nerve. So, Bell's palsy usually affects the labyrinthine segment and can lead to ischemia and palsy. And but the most commonly injured structure, most commonly injured part of the facial nerve in mastoid surgery is the second genu. Is that is the part of nerve arising after second genu, that is the vertical segment. It is most prone to injury, surgical injury during mastoid surgeries. When we are when we are doing a cortical mastoidectomy after, and when we do a canal wall up procedure, and when we are slowly drilling down the canal wall, and that ridge which is left, the facial ridge which is left, and when we are drilling down on it, it is the vertical segment of the nerve which is going into stylomastoid foramen. So that is most prone to injury during mastoid surgeries. So, which is the surgery which has the highest risk of chances to injury to facial nerve? It is not mastoid surgery; it is parotid surgery. Parotid surgery is the most common surgery where we can do a iatrogenic injury to the facial nerve. But if talking particularly about ear surgery, then which segment of facial nerve is injured? It is vertical segment. So most common surgery which causes injury to facial nerve is the parotid surgery. But when but during ear surgery, the most common segment which is injured is vertical segment. So coming to branches of facial nerve, within the facial canal, as I told, there is a branch called as greater superficial petrosal nerve. Then from the vertical segment, two branches are there: nerve to stapedius and chorda tympani nerve. After it, in the stylomastoid foramen, it will be sending one posterior auricular branch and then muscular branches to styloid and posterior belly of digastric. In the face, the branches are temporal, zygomatic, buccal, marginal, mandibular, cervical branches. These are the five branches which are forming pes incineralis when they are present between the when the nerve passes from the parotid and it is present between the superficial and deep lobe, and they come out as five branches like uh, like a foot of a goose called as pes incineralis. Now, these are just exam questions. They can be exam questions. Therefore, I have put this slide. What is the nerve? What is the blood supply of the facial nerve? It is from the five branches. One is anterior cerebellar artery, then the labyrinthine artery, then the superficial petrosal artery, and then when it comes out from the stylomastoid foramen, that part is supplied to the stylomastoid artery, which is a branch of posterior auricular artery. This vessel is important because while dissecting the facial nerve, near the tragal pointer, or when we are identifying the facial nerve in the parotid surgery, this artery usually bleeds and causes troubles of bleeding. And if it starts bleeding and we try to control the bleeder immediately with a cautery, this can cause injury to the facial nerve. So this is a troublesome branch. So just remember this name because it has been asked in the question. It is a repeat question. It has been asked one or two times in the super specialty entrance. Then the venous drainage parallels the arterial blood supply. Now, coming to surgical landmarks of facial nerve in ear surgery, which is less important for head neck entrance, more important is surgical landmarks of facial nerve during parotid surgery. Just revising the surgical landmarks in ear surgery. Number one is the process of cochleoformis, which is first genu. Then comes short process of incus, nerve lies medial to the short process of incus. In short process, incus is also called as the pointer towards the facial nerve. Then, so nerve lies just medial to the short process of incus. It is present at the level of editus. Then the nerve is also present between lateral semicircular canal inferior to it and between oval window. Nerve lies superior to it. So it is between lateral semicircular canal and oval window. Nerve lies posterior to the pyramid and nerves. leaves the mastoid at the anterior end of the digestive muscle. So these are the five or six landmarks for ear surgery. Now the more important landmarks, that is the landmarks of parotid surgery, are tympanomastoid suture, tragal pointer, styloid process, and posterior belly of digestive. So the most commonly utilized landmark in parotid surgery by the surgeon for identifying the main trunk of facial nerve is the tragal pointer. You should know that the nerve lies 1 centimeter anterior and inferior to the tragal pointer. So this in the parotid surgery, the pointer to the nerve in parotid surgery is tragal pointer, and the pointer to the nerve in ear surgery is short process fingers. So the nerve lies 1 centimeter anterior and inferior to the tragal pointer in parotid surgery. This is the most commonly utilized landmark. But the most reliable landmark or the most constant landmark is the tympanomastoid suture, and the nerve lies 6 to 8 deep to this suture. So if they ask you which is the most common landmark, tragal pointer, which is the most reliable landmark, it is the tympanomastoid suture, like. And also styloid process and digestic, the nerve lies lateral to the styloid process and medial to the posterior belly of digestic. So these are the four landmarks you should remember. Now, coming to a very important classification system, that is House-Brackmann facial grading system of facial nerve injuries. So facial nerve injuries can be divided from grade 1 to grade 6, where grade 1 is absolutely normal and grade 6 is total facial palsy, where there is no movement at all. So, how to learn this House-Brackmann facial grading system? Because this is a sure shot exam question in your practical MS exit. They will surely ask you about House-Brackmann facial grading system. So, number one is normal, when there is normal facial function in all areas. Number two is mild dysfunction. So, first you should remember that House-Brackmann talk grades the facial palsy on the basis of three terminologies, that is gross facial function, what is the facial function at rest, and the motion of the forehead, eye, and mouth. So, in mild dysfunction, gross facial function, there is slight weakness that is noticeable on close inspection. In grade 3, there is obvious but no disfiguring difference. In grade 4, there is obvious weakness, and in grade 5, there is only barely perceptible motion. So you can see that there is the obvious weakness is coming from grade 4. So grade 4 is very important, House-Brackmann. In the gross component of this grading system, there is obvious weakness is coming in grade 4, and and also when you see symmetry at rest, all the time there is normal symmetry tone. In grade 2, grade 3, grade 4, there is normal symmetry and tone, but in grade 5 it is becoming asymmetry. So what are the important things you should learn? Number one is that asymmetry at rest comes from grade 5, and other thing you should remember is eye closure is complete with maximal effort till grade 3. From grade 4, eye closure becomes incomplete. In grade 5 also it is incomplete, but how to differentiate eye closure of grade 5 versus the how to differentiate the how to differentiate the 1 second. So how to differentiate between the eye closure of grade 4 and grade 5. In grade 5 eye closure, there will be Bell's phenomena. What is Bell's phenomena? That when the patient tries to close his eyes, there's uprolling of the this uprolling of the this cornea. You can see that when the patient tries to close his eyes, there is a Bell's phenomena, which is a protoptic phenomena. When that is when that is the this cornea uh, goes uh, goes and hides above in the Bell's phenomena. So Bell's phenomena can be easily visualized in grade 5, but not in grade 4. So because in grade 5 the eye closure is incomplete, that it is more open. So if it is more open, so we can see the Bell's phenomena, that is uprolling of the eyeball in grade 5, but it cannot be seen in grade 4. So that is how we differentiate the incomplete closure of grade 4 versus grade 5. So I told you important points to learn is that the incomplete closure starts from grade 4. Incomplete closure is also present in grade 5, but we can see the Bell's phenomena also in grade 5. Asymmetry at rest starts from grade 5. So these are the important points you should remember, that eye closure becomes incomplete from grade 4. Asymmetry becomes at rest. Asymmetry comes from grade 5. Eye closure is also incomplete in grade 5, but Bell's phenomena is present. So these are the 3 4 points. If you remember, you can easily remember the full grading system. So grade 1 is completely normal, and grade 6 there is no movements at all. And also the components, you should remember that we see the cross component, we see symmetry at rest, symmetry and tone at rest, and we see motion of the forehead, eye, and mouth. And also you should remember that from grade 4 there is no motion in the forehead. Forehead motion goes from grade 4. So what is happening in grade 4? Grade 4, the eye closure is becoming incomplete. The forehead motion is becoming zero, that is none. And in grade 5, what things are coming? Eye closure is incomplete, we know, and asymmetry at rest is coming from grade 5. So these are the things you should remember in this classification system. Now coming to the electrophysiology, electrophysiological testing. If a patient comes with facial nerve palsy, how we will know that how bad it is, how bad is the palsy? That is, whether patient can be reanimated or not. If a patient comes to you with a facial nerve palsy, the most after a parotid surgery, if a patient presents to us after 1 year with a facial nerve palsy, or after 6 months with a facial nerve palsy, we need to know whether that patient can be reanimated or not. So it is the electrophysiological testing is must to find out whether we can reanimate our patient. So that's why I've kept 2 3 slides for electrophysiological testing. After electrophysiological testing only we can proceed further. So it is useful in prognosis and selection of patients for different treatments. So you should remember that for the lines how electrophysiological testing helps. It is useful in prognosticating and selection of patients which treatment to be given. Which treatment to the patient has to be given will be decided by the electrophysiological testing. So there are 4 types of tests: nerve excitability test, maximum stimulation test, evoked electroneurography, also called as 𝐂𝐫𝐞, and electromyography, also called as EMG. So a nerve excitability test and maximum stimulation test is not important. It is of historical value, and 𝐂𝐫𝐞 and EMG are the basic electrophysiological testings which is done these days. So just quickly telling about nerve excitability test, it compares the transcutaneous current threshold required to elicit minimal muscle contraction. That is at what's minimum threshold of the current the electric response is coming. So that so obviously with the when there's a nerve palsy, or when there's a problem with the nerve, threshold on that injured side will be more, that is more current is required. So if there is a difference of 3.5 milliampere of or more in thresholds between the two sides, it has been proposed as a reliable indicator of progressive degeneration. So this is now excitability test if there is a difference of 3.5 milliampere. So this in this you should remember this value, that if there is a difference of more than 3.5 between the thresholds, then that there is a sign of progressive degeneration. The other is a maximum nerve stimulation test. In this, we are doing opposite. In this, we are doing giving a maximum nerve stimulation of 5 milliampere, and we are seeing the response of the muscle on both sides. So movements of the paralyzed sides will be obviously decreased, and we are grading it as a percentage of the normal side, whether it is 0, 25, 50, 75, or 100% of the movement of the normal side. Generally, if it is more than if the difference is more than 25% of paralysis, that is, if the grading of movement is decreased by 25%, then it is considered as significant for maximum stabilization test. Now coming to the most important part, that is electroneurography. What is electroneurography? It records the compound muscle action potential, and surface electrodes are placed in the nasolabial fold and the stylomastoid foramen. The stylomastoid foramen we give stimulus, and response is seen in the nasolabial fold. And so if there is more than 90% degeneration within 14 days, just remember this line, it will come exactly in your exam. If there is more than 90% degeneration within 14 days, then their prognosis is poor. That is, there is a high chance that the become nerve is getting injured. There is no chances of recovery of that nerve. If there is a more than 90% degeneration within 14 days, the chances of recovery are very less. But this test should be done only after 4th day. The first 3 days is the time when Wallerian degeneration of the nerve is happening. So this test is not useful in the first 3 days. It should be done after 4th day, and also it has no value after 21 days because deblocking of nerve starts. So it has to be done between 4th and 21 day. This test has to be done between 4th and 21 day. Remember, don't do it before the 4th day because variant regeneration is not happening, and don't do after 21 days because of deblocking. Now, the other test is electromyography. What is electromyography? It records spontaneous and voluntary motor unit potentials of the orbicularis oculi muscle and the orbicularis oris muscle. So this test is done only after 3 weeks of onset of paralysis, and it is done when 𝐸𝐵 is showing degeneration, that is more than 90% degeneration is occurring. Then only we do EMG. So EMG tells us about three things: whether it confirms the 𝐸𝐵 findings, whether there is evidence of degeneration. So it is confirming the 𝐸𝐵 finding. So if there is evidence of degeneration, we'll see fibrillation. In EMG, we'll see fibrillation markings. Like the response in electromyography will be fibrillations, and it is usually present at after 2 weeks. So fibrillation on EMG are evident after 2 weeks. Now, after a patient has fibrillation on EMG, there can be two pathways. Either the fibrillations will continue and it will become a dead muscle, that is, motor end plates will become dead and there will be electrical silence. So, after EMG shows fibrillation, that is signs of degeneration, it can go a path of electrical silence or muscle dead, or it can go a path of re-innervation. That is, if it is following the path of re-innervation, we can see polyphasic innervation potentials which occur after 4 to 6 weeks of nerve injury. So what are the four responses of a EMG? Either it is normal or it is taking a path of degeneration. If it is taking a path of degeneration, it is called as fibrillation. It can continue the path of degeneration as electrical silence, or it can come back as reanimation potentials. That is, the nerve is trying to heal itself. So fibrillation potentials typically arise 2 weeks following injury. With regeneration of the nerve after injury, polyphasic regeneration potentials occur 4 to 6 weeks after these fibrillations. That is, after 2 weeks of injury, fibrillation potential come, and after 4 to 6 weeks, either the muscle can become silenced electrically or there can be signs of reanimation. That is polyphasic reanimation potential. And if once these polyphasic reinnervation potentials start in EMG, it is a good prognosis and it shows that clinical recovery will come. That is, you can see clinically the recovery within 6 to 12 weeks. So see how important this EMG is in deciding our further plan. So how the plan is decided: if polyps of the EMG potentials to show regenerative process, that is, reanimation occurs, surgical intervention is not required. You can cancel your surgery intervention. The nerve will recover of its own. If there is fibrillation is continuing, there is no polyphasic reinnervation, then it indicates lower motor and neuron denervation. But the motor end plates are viable. That's why fibrillation is occurring. So if you can provide some current in that area, that is, if you can provide some nerve from some other sites, like from cross facial nerve graft or hypoglossal or mesenteric nerve, if you can provide, then that area will start working. Because the end plates are not dead, only the nerve is injured. You provide some current, it will start working. But if there is on EMG shows electrical silence, then there is no option. You have to do a muscle transfer. That is, now the muscles. If there is electrical silence, that is motor end plates are gone. You have to put a new muscle or a free free muscle graft or a transposition graft like a temporalis or masseter or a free graft. The muscle there is no use in restarting the nerve conductivity. That is, there is no that is, if electrical silence occurs, nerve transfer procedures won't work. Only muscle transfer procedures will work. Nerve transfer procedures will work in fibrillation, and if there is re-innervation potentials are seen, no need of doing any surgical intervention. Now, what are the limitations of electrophysiological testing? Number one, it cannot differentiate between axonematis or neuronematitis. It provides no useful information of incomplete facial palsy, and it fails to provide any information in the immediate post-op period, that is within the first 72 hours, because voluntary degeneration is not complete. So, how our choice of reanimation is decided on the basis of this electrophysiological testing. First thing we have to see is the duration of paralysis. If the duration of paralysis is less than 24 months, because if duration of paralysis is more than 24 months, then the muscle motor end plates are surely gone. You only have one option, that is free muscle transfer or muscle transposition. If duration of paralysis is more than 2 years, muscle motor end plates are gone. You cannot do anything. Only if it is less than 2 years and EMG shows fibrillation, do a neural procedure, that is, do a nerve transfer procedure. If EMG shows polyphasic action potential and improving, reanimation can be postponed. The nerve will recover on its own. And if it is more than 2 years or EMG is showing electrical silence, then you have to do muscle transposition procedures. So coming to surgical treatment of facial nerve injury, There are many techniques. Facial nerve decompression is mainly used in mastoid surgeries when we by mistake injure the second genu area or the vertical segment area. So we have to decompress from first genu to second genu. Everything has to be decompressed. That is facial nerve decompression. That is not important in head neck surgery. Important here is from B, that is nerve repair, which can be done by direct end-to-end anastomosis or interpose. If the defect is more than 17 we can do a cable grafting with a sural or greater auricular nerve. Then other if that this is possible if proximal supply of facial nerve is coming, like, so this is your facial nerve, and if this suppose this segment is cut, you can repair it primarily. You can do a primary repair or you can put a graft, but this current should be working. If this current is not if not working, then you have to put two nerve transposition techniques. That is, you have to get current from somewhere, some other area, like you have to get current from hypoglossal nerve or mesenteric nerve or a cross facial nerve graft. So if the proximal nerve is not working, you have to provide other sources of current like a mesenteric nerve or a hypoglossal nerve or a cross facial nerve graft. Then if there is electrical silence, I already told you have to do muscle transposition procedures like temporalis and masseter, or you can do free flaps like gracilis. Or if the patient is not fit for these procedures, then static procedures. These are called dynamic procedures, and then static procedures like eye implant or facial sling can be built if a patient is not fit for D&E procedures. So we'll start with nerve repair procedures when proximal input is present. These are called as nerve repair procedures. So primary anastomosis, that is, if the defect is less than, if you have injured the facial nerve and the defect is less than 17 we can do primary anastomosis. It has the best outcomes. The endoneural segments must match. That is, the suturing is done in such a way that endoneural segments must match. That promotes regeneration. So ends are sutured together using 90 or 10-0 monofilament sutures to bring the epineurium or perineurium together. It is best to freshen the ends of both the nerve and graft by making an oblique 45-degree cut. If you make an oblique cut at the dead end to remove that neuroma, so the cross-section area of the nerve increases for the anastomosis. So before doing anastomosis, give an oblique cut to the cut end of the nerve, because at that end there is the chances that there will be a neuroma or small dead area. So if you cut it and freshen it and then suture, then the chances of recovery increases. So if the defect is less than 7 we can do 17 we can do primary anastomosis. But if the defect is more than 17 there are two options. Either we do a greater auricular nerve grafting or a sural nerve grafting. Greater auricular nerve grafting can be done up to 10 centimeter of defect, and sural nerve grafting can provide up to 70 centimeter of defect. But the problem with sural nerve is there is a diameter mismatch with facial nerve, but greater auricular nerve diameter matches nicely with the facial nerve. And also, you should remember that the graph which we are taking, that is greater auricular sural number, should be 25% longer than the defect of the facial. Now, coming to nerve transfer procedures. So, as I already told, nerve transfer procedures are used only when the proximal supply is not coming. That is, proximal supply is also dead. Then you can use nerve transfer procedures like hypoglossal nerve or mesenteric nerve or cross facial. So I'll tell you in parotid surgery when such situation occurs. Such situation arises when you have cut the main stump. Suppose the main stump has been divided, it has retracted into the stylomastoid foramen, and there is no chance of getting that proximal stump of facial nerve. When there is no chance of getting that proximal stump, or it was invaded too much, it was invaded till skull base. If suppose we are operating adenoid cystic carcinoma of parotid and there was perineural invasion in the facial nerve, and that proximal stump was invaded so much till the that we kept on drilling the stylomastoid foramen, and it was going till the stylomastoid foramen till here the perineural invasion was present. So obviously now we cannot get that stump to provide current. The rest of the peripheral branches have to be supplied from some other nerve. So this is the situation when we do nerve transfer procedure. And primary anastomosis or grafting are the procedures when we do. Suppose when we have injured temporal branch, some part of temporal branch has been injured or cut, then we can immediately do a primary anastomosis or grafting procedures. So coming to nerve transfer procedures, number one is hypoglossal to facial. We can take hypoglossal end to side anastomosis can be done with facial. We can take the nerve to masseter and anastomose with the facial nerve. or we can take cross facial nerve graft with the help of sural nerve. We can harvest sural nerve, and branch-wise grafts can be taken. From every branch, graft can be taken via sural nerve and attached to the peripheral branches. So these are the three options: hypoglossal to facial, mesotic to facial, or cross facial nerve graft. So it consistently provides some restoration of function, and the prerequisites for nerve transfer procedures are: there's a reversible facial nerve injury, the mimetic, that is motor end plates are functioning, the intact motor end plate, there is intact motor end plate function, there is intact muscle function, and there is intact distal facial nerve. Obviously, if the distal facial nerve is intact, then only these nerve transfer procedures can be done. So hypoglossal to facial transfer, we do end-to-side anastomosis. We take one segment of hypoglossal nerve, we cut it half and suture it with facial nerve, or we took a jump graft or greater auricular nerve between hypoglossal and facial. That jump graft provide conductivity between the hypoglossal and facial nerve, and rest of the side part of the hypoglossal nerve can continue supply the tongue. So that is why it is an end-to-side anastomosis. End anastomosis is with facial nerve and side anastomosis is with hypoglossal nerve. So since the hypoglossal nerve is transected only halfway, tongue function can be preserved. Now, coming to mesenteric nerve transposition, the advantages of the hypoglossal is that the position of nerve allows direct anastomosis. We don't need to take a auricular nerve jump graft. There is a strong motor impulse. Renervation occurs quickly within 3 months. There is absence of morbidity because it is the same site, and masseter muscle is less important muscle than the tongue muscle, where hypoglossal is supplying, which is more important. So morbidity is comparatively less. So nerve can be easily isolated on the surface of masseter, transected distally and transposed superficially. That is the muscle, the masseter nerve and the nerve to masseter, that is mesenteric nerve, and that is supplying the masseter muscle, can be cut and can be instead sutured to the facial nerve. And the smile is also mesenteric driven. When there is intent to smile, it is a mesenteric driven smile. That is, the impulses are going to mesenteric. The mind thinks that the impulses are going to the our muscles of mastication, the mesenteric nerve or the mesenteric muscle, but instead it goes to the facial nerve and the patient smiles. So that is the meaning of a mesenteric driven smile. Just remember it. Uh, Now coming to cross facial nerve graft, that is, it is required when we require specific division control. That is when we need to run a particular division of the facial nerve. So the best thing about cross facial nerve graft is provides emotional animation. Uh, that is, since it is coming from the facial nerve only to the other facial nerve, so our brain doesn't get confused which nerve to stimulate for that activity. So the brain knows that I have to, like for smiling, I have to stimulate the facial nerve and the patient will smile. It doesn't get confused that I have to stimulate the hypoglossal nerve or the mesenteric nerve. That is what is meant by emotional animation. So it has a capability of specific divisional control. So what is happening here is that sural nerve grafts, this is the intact facial nerve and this is a damaged facial nerve. Sural nerve grafts are taken from the intact facial nerve to the damaged facial nerves, and when ingrowth occurs, so whatever current is coming here to these muscles is also conducted similar to the exact same branch on the other side. So it has a capability of specific division controls. The sural nerve grafts are taken currently, but cross facial nerve graft is not used mostly in the nerve transfer techniques. In nerve transfer, only hypoglossal and mesenteric is used. Cross facial grafting is a compulsive technique, so it is currently most commonly it is used only when we do free muscle transfer. I will show you how free muscle transfer cross facial nerve graft works, and sometimes this cross-facial nerve graft maybe is usually done in two stages. In the first stage, we have to connect it to the intact intact area. First, we connect it to the intact area, and when the neural ingrowth occurs, then we do anastomosis of the paralyzed area. So it is done in two stages. So four separate grafts from temporal, zygomatic, buccal, and minor medullary divisions of the normal caneus nerve 7 to the corresponding divisions of the paralyzed are taken. That is what I explained. So in this slide, this slide is self-explanatory for cross-facial nerve grafting. Now, now suppose these were the situations when the motor end plates were functional. When the motor end plates are not functional, or when they are more than 2 years of the injury, that is when facial nerve interruption of at least 2 years have occurred, there is loss of motor end plates, or when there is a congenital absence of the facial system, that is there is congenital facial palsy. Then we can use muscle transposition technique. which are of two types, that is temporalis muscle transposition, which is the most commonly used technique, and the second most common is masseter muscle transposition technique. And for both of these techniques to work, trigeminal nerve must be intact. Muscle transposition techniques are also called as dynamic sling techniques. You should remember that these are local muscle transposition flaps. These are not free flaps. Free flaps we'll be discussing later. So for both these muscle transposition techniques or these dynamic string techniques, the trigeminal nerve must be intact. Uh, so what is happening in temporalis muscle transposition? We are taking this temporalis muscle and we are just transposing it to the angle of mouth or in the eye area to provide that function which was done initially by the orbicularis oris or the orbicularis oculi or the orbicularis oris. This function is done by the temporalis muscle slings. So, by the temporalis muscle. So, muscle transposition most commonly implies the temporalis muscle because of its good location, that is nearby location, the length, the contractility, and most important is the vector, that is the correct vector of pull for the smile. So, it is typically reserved for reanimation for corner of mouth. It is most commonly used for reanimation of of the corner of mouth, and the vector causes that area to be pulled superiorly and laterally, which is our intent that the smile occurs. So the vector is useful. That the vector provided by the temporalis muscle pull is useful and is more physiological. Now, the second most common muscle transposition technique is the massetic muscle transposition. So, it is used when the temporalis muscle is unavailable because of any because of any previous bone resection or some reconstruction. When temporalis muscle is not available, it is rarely a case when temporalis muscle is not available, and we take a masseter muscle for transposition. So, the problem with masseter muscle transposition is that the vector force of the pull of the muscle is more in horizontal plane as compared to temporalis muscle, where it was more superiorly and laterally. Now, another technique is a temporalis tendon transfer. That is the full complex of the coronoid complex. That is where the coronoid complex, where the temporalis muscle tendon is attached. It is taken and sutured to the modulus, that is the angle of the mouth. And if there is any gap in that area, a facial artegraft can be used to bridge that gap. So full coronoid tendon complex is fixed to the modulus. So it is also just a technique apart from temporalis muscle transposition, masseter muscle transposition. Just remember that temporalis tendon transfer is also a technique where the full complex is taken to the modulus. And advantage is it is a single skin incision. It prevents bulkiness of the temporalis muscle. In previous situations when we were taking temporalis muscle, the bulkiness can be present over the zygoma, which is not present in that. And also the natural vector pull is present, like in temporalis muscle transfer. In temporalis tendon transfer also, the natural vector of pull is available. Now coming to free muscle flaps. Free muscle flaps are used when we are not using muscle transposition. The indications are same. When there is electrical silence or motor end plates are not functioning, then we can take a free muscle flap. It is also called as a micro neurovascular free flap transfer. Here it is important that apart from vascular free flap, for a free gracilis to survive, we also need the neural grafting, that is neural anastomosis, should also be done so that the gracilis muscle can respond to the stimulus which is being provided by the brain. So it is a neurovascular free flap transfer instead of a vascular free flap transfer. So most important muscle for facial reanimation, for free muscle flaps used for facial reanimation, the most common muscle used is a gracilis muscle, and the less other commons are serratus anterior, latissimus muscle, also pectoralis minor, but most common is the gracilis muscle. So it is the ideal tonal muscle, and it is the artery which is based is the medial circumflex artery, and the nerve which is used is anterior branch of obturator nerve. It is usually completed in two stages. So what is happening here is, in the first stage we are taking a cross facial nerve graft. That is, suppose this side muscle is suppose this side muscle is paralyzed. So what we are taking sural nerve grafts, and we are inserting those grafts here in on the normal side. This side is paralyzed, so we are inserting the sural nerve grafts on this side. And once this anastomosis completes, that is in the first stage when this cross facial graft is set, that is this neuroanastomosis starts functioning. Then only we'll do a second stage where we will take the gracilis muscle and put it here, and on that anterior branch of that obturator nerve of the gracilis, the other end of the sural nerve will get anastomosed, and that is called as second stage. So second stage is only done after there is neuronal ingrowth of the first sural nerve grafts. Once it takes up, then only we do a second stage. But one way to avoid this two-stage procedure is when we are doing when we are anastomosing masseter nerve with the obturator nerve. When we are doing with the masseter nerve this anastomosis, then it can be a single stage. But if we are doing it with the normal facial nerve of the other side, then we have to do two stage, because we have to take a cross facial nerve. So if masseter nerve is used as a donor nerve, it is a single stage masseter nerve innervation to the gracilis. So you can see in this diagram here the gracilis free flap is taken and inset here, and the nerve supply of the gracilis, that is obturator nerve, is anastomosed to the masseter. So these are all other dynamic procedures. Now coming to static procedures which can be used are tarsography or canthoplasty, eyelid implant, facial sling or chemo denervation using botulinum toxin. So what is facial sling? Facial sling is used. So these static procedures are used when a patient cannot undergo a muscle transposition technique, or when a patient cannot undergo free muscle transfers. That is a debilitated patient or not a good performance status patient for general anesthesia. Then we use these static procedures. Number one is a facial sling. So it is used in debilitated patient with poor prognosis of survival. And now, or when the nerve of muscle is not available for dynamic procedure, we use facial sling using polytetrafluoroethylene or alloderm or facial lata, and we just suture it over that area so that that angle of mouth problem is gone. The second is the lateral tarsography. It is useful to prevent dryness of eyes. So basically, on the lateral part of the eye, where we suture the upper and lower lid together, so that 4 to 6 mm of margin is decreased. If 4 to 6 mm of this margin is decreased, then the dryness or the keratitis can come down. So we use 70 silicone nylon for that, and 4 to 6 mm of that area from lateral canthus is reduced. So suturing occurs at the gray line or the mucocutaneous junction of the upper and the lower lids. It is also called as lateral tarsography. And third is a gold weight implants, where we put gold weights above the tarsal muscle, so that at night when the patient is sleeping, then the eye is not open, and with the weight of that of that gold, the eye should fall down and there is no exposure keratitis. So here the incision is given the supratarsal crease, 8 to 10 mm incision is given, and tarsal plate is exposed, and 1 to 1.2 gram of gold implant is inserted in between the tarsal plate and the muscle, and exact weight is determined preoperatively, and then it is put. So the disadvantage of this procedure is extrusion, number one, or when the patient is lying supine, sometimes it can open up because of the weight of the gold. But mostly, the most commonly used static procedure to close eyes is the gold weight implant. So just remember that in this technique, we are inserting this gold plate in the supratarsal crease, over the tarsal plate muscle, and around 1 to 1.2 gram of implant is inserted between the tarsal plate and the muscles. And finally, there is chemo denervation, in which we give botulinum toxin and denervate those muscle areas, and can eliminate the synkinesis which is happening after facial nerve injury. So it is basically used to eliminate inappropriate movements caused by synkinesis. So around 1 to 5 units of is injected per site. It takes around 3 to 6 months to work. So just summarizing my topic with this table. Whole topic can be summarized with this table. So if the paralysis is more than 2 years, that is a prolonged paralysis. That is, the motor end plate function is gone. Now nerve transfer techniques won't work. Then you have to do then you have option of muscle transpositions or free muscle transfer. So if it is a good surgical candidate, then you can do dynamic sling, that is muscle transposition procedures, which can be a temporalist muscle transfer or mesenteric or muscle transfer, or you can do a free muscle transfer, which is most commonly a gracilis muscle transfer. Or if the patient is a poor surgical candidate, then you have to do static procedures, which I just discussed. Now, if it is a prolonged paralysis. If it is a recent paralysis and proximal nerve input is intact, then if it is a small injury, do a primary repair. If it is more than 17 mm injury, do a greater auricular nerve graft or sural nerve graft. Or if multiple mulches are involved, then you do a sural nerve graft. But for all these procedures, proximal nerve should intact. If the proximal nerve input is absent, like in adenoid cystic carcinoma, where the drilling has been done till the skull base, you don't have proximal nerve input, then you can do nerve transfer procedures like I discussed, hypoglossal nerve transfer, mesenteric nerve transfer, or a cross-facial nerve. So this was a summary of the topic. It's an important topic and a conceptual topic. Just go through the slides repeatedly to understand it. One question they will definitely ask for facial reanimation, because it's why this topic is important, because it's an important situation which is arising after a parotid surgery for a malignancy when the facial nerve is injured, and most of the people don't know about facial reanimation, and patient suffers from grade 5 or grade 6 palsy, which is highly debilitating, highly cosmetically challenging for the patient. So facial reanimation is the upcoming thing for plastic surgeons and head neck oncologists, and we should know how to manage this complication of parotid surgery. Thank you.